Okay, good evening, good afternoon, and good morning, everyone, depending on where you are on planet Earth. And I would like to welcome you at the IARS Virtual Education section. And first of all, I'd like to thank the IARS choosing us from SmartTots to talk about the behavior and cognitive changes in children following anesthesia and give you some thoughts on the assessment and the relevance of this topic. Can I have the next slide, please? So we have nothing to disclose in terms of commercial support. And these are the details you will receive regarding the virtual education and CME credits. You will all receive this by email. And you will have a QR code as well to get access. So today, so the recording will be available at the IARS website for members. And during the 4 talks, you can submit your questions, and we will have the question and answer session after the end of the 4th talk to get all the material together to discuss. So next slide, please. So today we will have 4 speakers. The first is Dr. Andrew Davidson from Royal Children's Hospital, Melbourne. I don't really think that we would need to introduce him. He'll talk about the understanding post-anesthesia delirium in children. And then Caleb from Columbia University. He's an associate professor at Columbia University. He's a pediatric anesthesiologist. He will talk about the behavioral outcomes following anesthesia exposure, what really counts. And what is, I think, very interesting in our webinar, that we also have 2 non-pediatric anesthesiologists, 2 PhD in psychology, in pediatric psychology, Dr. Kristen Uhl and Dr. Cynthia Salorio, who will talk about measuring postoperative behavior in children and also on the neuropsychological assessment of children following anesthesia. So I would really like to thank all our speakers to accept speaking for this. And so we will have the 4 talks, and without any further ado, we could start that, and then just type your questions, and then we will have a time for discussion. Thank you very much.
Thank you for asking me today to talk about understanding post-anesthesia delirium in children. I have no financial relationships with commercial interests to disclose. Post-anesthesia delirium in children typically occurs on emergence from anesthesia. It is common and occurs mainly in preschool children. Its reported incidence varies greatly. This variation is partly due to the differing definitions and the different measures used when assessing emergence delirium. Emergence delirium needs to be differentiated from emergence agitation. It's useful to consider 4 different and partly overlapping definitions or concepts. That's postoperative delirium, emergence delirium, hypoactive delirium, and emergence agitation. Note that it's not always easy to differentiate these. Delirium is classified under the DSM-4/5 criteria as having reduced awareness of the environment, being non-responsive, and having altered cognition or perceptual disturbances, being disoriented. If we consider the postoperative period, children could be agitated, or they can have delirium, or they can have both. If they have both, this is what we classically refer to as emergence delirium. In a delirium state, the child is non-responsive, disoriented, has no eye contact. Agitated children are often crying, screaming, thrashing, or punching. If you put them together and have emergence delirium, they have all these, plus often a fearful or trying to escape behaviour. Note that you can also have hypoactive delirium, where there is no agitation, but the child still has no eye contact, is non-responsive, and is disoriented. Amongst the various scales to measure postoperative delirium, Crivero's scale is a 5-point scale which measures mainly agitation, the Crivero Emergence Agitation Scale. The Watcher scale measures emergence delirium and has measures of both agitation and delirium. The PED scale, which is used most frequently, measures 5 different dimensions on a 4-point scale. 4 of those dimensions are really delirium and 1 measures agitation. The Cornell assessment of paediatric delirium was originally designed for children in ICU, but can also be used in a post-operative setting. This measures 8 dimensions with a 0 to 4 scale, and all those dimensions are basically measuring delirium rather than agitation. One recent paper showed that hypoactive delirium occurs in about 25% of post-operative delirium. The etiology of post-operative delirium or emergence agitation or emergence delirium is still largely unknown. We do know that rapid awakening seems to increase the risk of emergence delirium. Delirium itself has no specific EEG signature, which is consistent with other forms of delirium. There tends to be a mixed EEG picture, which can simplistically be seen as the brain being half awake, half asleep. Emergence delirium is interestingly less common if a child emerges from a state where the EEG represents light sleep. This is more frequently seen in emergence from propofol. Intriguingly, emergence delirium is quite similar to night terrors and in some ways have similar EEG patterns. Night terrors occur when the child is aroused from deep sleep. It's difficult to differentiate emergence delirium from pain, as pain will cause agitation. Delirium can certainly occur with no pain, but pain may precipitate delirium if it causes a rapid awakening and thus prevents light sleep. So if we think that pain increases the nociceptive stimulus, it may be you're more likely to emerge from a deeper state of anesthesia and hence more likely to develop delirium. Delirium and long-term behavioural outcomes. There's some evidence for an association between emergence delirium and long-term behavioural change. Most measures, however, of the long-term behaviour change use very suboptimal measures. Also important to remember that this is an association and it doesn't imply causation. It doesn't imply that post-operative delirium causes behavioural changes or that management of post-operative delirium will reduce long-term behavioural changes. Similarly, there's some association with preoperative anxiety, but it is not necessarily causative. There's weak evidence that some strategies that reduce preoperative anxiety also tend to reduce emergence delirium. This may, however, be simply due to providing better post-operative analgesia. Strategies to reduce emergence delirium. Midazolam pre-medication has no evidence for any efficacy in reducing emergence delirium. Alpha 2 agonists, such as dexmedetomidine or clonidine, whether they're given preoperatively or intraoperatively, have all been shown to reduce the incidence of emergence delirium. Intraoperative fentanyl has also been shown to reduce the incidence of emergence delirium. Gabapentin, melatonin, ketamine, magnesium, and acupuncture have all been shown to work to reduce emergence delirium in some small trials. It's interesting to note there's some evidence that deep anesthesia per se does not increase the risk. So if the child is run at a deeper plane during the entire anaesthetic, that doesn't increase the risk of emergence delirium. This is in contrast to some evidence in adults where it does. Emerging from propofol is the most effective way to reduce emergence delirium, whether that's by TIVA or whether it's by giving a 2 to 3 milligram per kilogram bolus at the end of the case. Note that it's important that enough propofol is given that the child emerges from the propofol rather than emerges from the volatile anaesthetic. Ways to reduce emergence delirium once it's occurring or manage it. Emergence delirium is self-limiting, usually lasts less than 20 minutes, but it may cause injury, dislodge, dressings and cannulae. Clonidine and propofol have both been used to treat emergence delirium. Fentanyl has also been shown to be effective. It's important to note that when treating emergence delirium, you have to exclude other causes of agitation as well, because it is difficult to differentiate emergence delirium from agitation. Agitation can be caused by pain, cold, hunger, full bladder, or fear. You can also cause delirium due to hypoxia, hyponatremia, and other metabolic causes. So in summary, it's important to differentiate agitation and delirium. Delirium may be hyperactive. Emerging from propofol is the most effective preventative strategy. It's important to manage other possible causes of agitation, particularly pain. and it's unknown if emergence delirium or postoperative delirium causes any long-term impact for the child. Thank you.
My name is Caleb Ng, and today I'll be talking about behavioral outcomes following anesthesia, what counts. I have no disclosures. Nearly 100 clinical studies have been published evaluating hundreds of different outcomes and outcome scores. These include academic achievement scores, clinical diagnoses for conditions such as ADHD, learning disability, and specific neuropsychological tests. There have been many patient populations that have been evaluated, including children undergoing different types of procedures, numbers of exposures, ages of exposure, and ages of evaluation. Given this vast amount of data, it's difficult to make sense of it. In an attempt to try to interpret the published literature, we performed a meta-analysis focusing on the clinical neurotoxicity studies, which are thought to have the most comprehensive assessment of children. These include studies in which children are physically brought into testing facilities and assessed using a prospective battery of neuropsychological tests. We did this because these studies were designed to use the most sensitive outcomes and also allowed for a review of clinical data in order to minimize confounding. We also focused on studies evaluating children exposed to a single general anesthetic and also evaluated children who were at least school-aged or greater, because assessment of older children is typically more accurate. We excluded all studies that focused on children with major chronic conditions, because figuring out the effect of anesthesia in children with major surgery and major underlying medical problems is very challenging. We ultimately identified 8 studies that met criteria. And since we wanted to do the cleanest study possible and ensure that we are comparing apples with apples and not apples with oranges, we only included results from studies where the exact same outcome measures were used, so we did not have to merge disparate outcome scores. We ultimately identified 3 studies which had overlapping outcomes. The first study is the PANDA study, which is a multi-center ambidirectional study evaluating children who received anesthesia and surgery and comparing them with their siblings with no anesthesia or surgery. The MASK study, which is a single center ambidirectional study that compared children receiving anesthesia and surgery with other children in the community who did not receive anesthesia or surgery. Both of these were observational studies. And the third is the GAS study, which is the only international blinded randomized controlled trial, which compared children who received sevoflurane general anesthesia with those who received an awake regional anesthesia for inguinal hernia surgery. The primary outcome for all 3 studies was IQ. In combining the data from all 3 studies, we found that there were 5 outcomes in common. The first outcome was intelligence, as measured by IQ. As you can see, all 95% confidence intervals cross 0, including in the combined results. So there is no difference in IQ scores with a single exposure. It is interesting to note that there is consistency in the results. Typically, an I-squared greater than 50 signifies serious heterogeneity, but here you can see the I-squared is 0, which signifies little or no heterogeneity between studies. It's also interesting to note that the GAS study results were overall quite consistent with the observational study results. The next outcomes are the CBCL scores, of which there's a total behavioral problem score, an externalizing behavioral problem score, which looked at problems like aggression and ADHD, internalizing behavioral problems like anxiety and depression. And overall, for CBCL, higher scores mean more problems and are worse. And what you can see here is that children with a single exposure to anesthesia have scores that are about 2 points worse than unexposed children, and that the size of the association is similar in all 3 studies. The final score is the brief, which measures executive function problems. And here you can see that children who are exposed had higher or worse scores by about 2.6 points. But this final score was not statistically significant after multiple comparisons adjustment. One of the tricky things about score differences is to try to figure out what a 2-point difference actually means from a clinical standpoint. To try to help with interpretation, we did a secondary analysis to determine if this 2-point difference found in behavioral outcomes was associated with an increased risk of developing a clinical deficit. We defined clinical deficit as a child having a score that was 1 standard deviation worse than the mean score, which translates to being in the worst 16% of all normalized scores. We found that children were not statistically significantly more likely to be in this lowest 16% deficit category for total behavioral scores or externalizing behavioral problems, but they were 47% more likely to have internalizing behavioral deficits and 68% more likely to have an executive function deficit. So the question that often comes up is, what are CBCL in brief? They are validated parent-reported surveys where caregivers will answer questions describing problems in their child's behavior or executive function. The follow-up question is that if these parents knew that their children got at general anesthesia, could they be biased in filling out the surveys? And could bias be the reason for the reported differences? We were able to explore that question using the GAS trial data in a secondary analysis. The GAS trial is interesting because 50% of patients or parents were blinded to the anesthetics that their child received. So they did not know if their child got a general anesthetic or a spinal. In the unblinded parents, the children got either a general anesthetic or a spinal, and the parents knew it. So if bias was present, the GA kids would likely be rated by their parents as having higher or worse scores than the regional anesthetic children. And again, if bias was present, in the blinded kids, where the parents did not know if the kids got GA or regional, there would likely be no difference in the scores since they did not know what their children received. But what did the results show? The unblinded parents were found to rate the GA exposed kids as having worse or higher scores, but the blinded parents also rated the GA kids as having worse or higher scores. So, at least in the GAS trial, parental knowledge of general anesthetic exposure did not appear to bias the survey outcomes. So, in summary, in evaluating the available outcomes in prospectively assessed children, no differences in IQ were seen between exposed and unexposed children. Exposed children had behavioral function scores that were approximately 2 points worse, which corresponds to an about 50% increased risk of clinical deficit. This suggests that in evaluating children exposed to anesthesia, behavioral function may be an outcome of interest to be evaluated. Thank you for your attention.
Hi, my name is Kristen Ewell, and I'm a psychologist at Dana-Farber and Boston Children's Hospital here in Boston, Massachusetts. And I'll be presenting today on measuring postoperative behavior in children. The objectives of my presentation are to discuss postoperative behavioral changes in general, and also the traditional forms of measurement for them. Next, I'd like to discuss the challenges related to that measurement. And finally, go over a reconceptualization of how we can consider relevant behaviors, constructs, and clinical significance related to this behavior change. It has long been observed that children may exhibit a range of behavioral changes after undergoing surgery or hospital stay. And these behaviors can include regressions related to bedwetting, thumb sucking, sleep or eating challenges, activity or place avoidance, aggression, as well as changes in play, school engagement, or social behaviors. In order to better assess these changes in a systematic way, Vernon and al., which was a combined group of psychologists and doctors, created the post-hospital behavior questionnaire. Questionnaire items were developed from literature review of common symptoms observed in children following their hospitalization. And it was validated among 387 parents of pediatric patients who were aged 1 month to 16 years and had recently been hospitalized. The results of the validation study suggested that the measure was moderately valid and also somewhat internally consistent. Since its creation, the PHBQ has been the gold standard among the academic medical community for assessing behavioral changes following surgery and hospitalization, particularly following ambulatory surgeries such as tonsillectomies or adenoidectomies. Studies using the measure suggest that up to 80% of children undergoing scheduled medical procedures requiring anesthesia may exhibit some level of negative behavior change in the days following surgery, with this number steadily decreasing across the following weeks. Research has also found evidence that anxiety, pain, and prolonged hospitalization may be related to the presence of these behavior changes. Additionally, studies have shown that there are certain interventions, both medical and non-medical, that may mitigate some of these behavior changes. Despite its common use, the PHBQ presents with many different limitations. First of all, the measure was created back in the 1960s. And as we all know, surgery methods, anesthesia, pain control, and hospital course have all changed significantly since then. Additionally, the validation sample was also from the 1960s. And the sample makeup itself was quite variable, including kids from 0 to 16 undergoing various types of surgeries and different durations of hospital stay. Next, the age range for the measure itself is very broad, claiming applicability to youth from infancy all the way to 18 years of age with the same question items. And developmentally, we would not expect children across this age range to respond in the same manner to hospitalization. And what might be seen as a negative behavior change at one stage may not be seen as such at another. The measure also does currently not take stage of development into account. And based on item content, younger children are much more likely to have higher scores. There is also no universal scoring system or clinical cutoffs. And because of this, different researchers are able to apply different metrics to what actually constitutes significant negative behavioral change. Finally, since the measure was developed looking at observed behavior changes after surgery, as documented in 6 previous studies, it isn't clear whether these changes are clinically significant or what they even represent. Recently, Jenkins et al. Have addressed some of these concerns by creating a modified ambulatory surgery version of the PHBQ. But the new version still lacks a clear construct and clinically significant cutoffs. So in reconceptualizing these post-hospital behavior changes, the first question we ask is what they actually represent. As I mentioned before, it's quite possible that some of these behaviors may represent normal stress responses that children can have following surgery and anesthesia, while other behaviors may be signs of more clinically significant concerns. Psychological research suggests that clinically significant behavior changes observed after medical experiences can be considered representations of pediatric medical traumatic stress, or PMTS. And this construct includes a range of psychological and physiological responses observed in diagnosable adjustment and stress disorders. In using this framework, behavior change can be mapped onto diagnosable psychological disorders, such as acute stress disorder, adjustment disorders, and post-traumatic stress disorder. So, in an effort to improve this understanding and measurement of post-hospital behavior changes in children, I've collaborated with a multinational, multi-institutional group of researchers to develop what we're calling the Post-Hospitalization Adjustment Questionnaire, or PHAQ. An expert panel of anesthesiologists and psychologists, as well as the Diagnostic and Statistical Manual of Mental Disorders, were both used to develop questionnaire items consistent with pediatric medical traumatic stress. And the decision was made to create developmentally specific versions of the questionnaire, the first of which is for 2 to 6-year-olds. The questionnaire has been reviewed by members of 2 different hospital parent networks for content and understanding, and will soon be entering a validation phase. It's my hope that this will begin to pave the way to a better understanding of normative and clinically significant responses in children after hospitalization or surgery with anesthesia. And we have so much more to learn, so please stay tuned. Like to acknowledge the many different people and institutions that have been involved, and also to share my references. Thank you very much.
Hi, I'm Cindy Solorio, and I'm going to be talking to you today about challenges in neuropsychological assessment of children following anesthesia. I have no disclosures, and my presentation will not include discussion of off-label or investigational use. So I only have 8 minutes. I'm going to jump right in. Challenge number 1 really surrounds what to even measure. We don't have a clear phenotype of anesthesia exposure and outcome. And when we do research in this area, for statistical reasons, we have to choose a primary outcome, quote unquote. And so most of the studies chose IQ. But we always knew that IQ was not going to be sensitive. It's reasonable to measure variables that have been implicated in the preclinical studies, so things like learning and memory, maybe anxiety. We should measure variables that have been suggested in the human anesthesia studies, so things like language, behavior, maybe attention. We should certainly measure variables that have been sensitive, shown in other studies to be sensitive to early exposure. So things like fine motor speed and dexterity, attention, executive functioning, processing speed. And we want it to be meaningful. So we should measure variables that are of importance to families and society. So things like patient-reported outcomes, quality of life. Or maybe we should measure everything and just see what sticks. And that's kind of been the approach for most of the studies to date. Hopefully earlier today, Dr. Ng talked to you about the systematic review and meta-analysis that came out recently that looked at all of the prospectively assessed neurodevelopmental outcome studies after single exposure. I think this meta-analysis is a really nice pivot point that lets us start to focus in on the most important outcomes and stop measuring everything. But I do think that there are a couple other challenges that we really need to wrestle with before we get to an ultimate phenotype, if there is one. Challenge number 2 is how to measure. Ideally, we want to be measuring directly observable behaviors, but the problem is cognition is not always directly observable. We can certainly use our clinician-administered age-normed neuropsychological tests, but these take time even for an individual child. And while we hope that they're measuring the underlying construct, some of them do a better job than others. We can use rating scales or parent report. One of the issues with this is potential bias. Usually they know their child's status and probably know that we're studying anesthesia exposure. We could use diagnoses, but that raises the question of what criteria. Are we talking about billing diagnosis or diagnoses done as part of a clinical evaluation? Or are we talking about diagnoses that are strict research criteria that everyone has to undergo? We can use large data sets such as medical records or school records, and that definitely gets us a higher end, more children, but some of those measures lack precision, and we're really looking for something that's probably kind of subtle. And it matters how we measure because these measurement modalities really don't correlate very highly. There's plenty of research to show that self-report versus parent report versus teacher report, particularly related to things like executive functioning and mood, really don't correlate very highly. In addition, the age norm tests really don't correlate very highly with diagnostic criteria. There are plenty of children with diagnoses of attention deficit hyperactivity disorder that can come into my office one-on-one and ace any attention test that I give them. And then there's the challenge of which measures to even use. This is actually a table from that meta-analysis. And what's really interesting about it is just the sheer number of tests that we use to measure these constructs. There are many tests available to measure each and every construct. And one of the reasons that this happened is because there are very few tests that span all of the age ranges that we're actually interested in. Also, most of these tests really tap into more than one thing. They aren't pure. There is no pure memory measure. Most of our memory measures also involve language or visuospatial skills. They all involve attention and processing speed and working memory. So it's very hard to find which test to even use. Challenge number 3 is when to measure. There's certainly argument to be made for measuring early. We want that assessment as close to the time of exposure as possible so that there's not time for intervening or confounding events or factors. Or even better, let's get a measurement before the exposure, and then we have a pre and post to compare after. The problem with this is that many children are very young at the time of exposure, and we know that early neurocognitive assessment in infants and toddlers, particularly IQ, has very limited predictive value for the future. There's also arguments to be made for measuring late. We want to have a longitudinal assessment as far away from the exposure as possible so that we're sure that the effects are lasting. Also, the preclinical data suggests that it takes some time for the deleterious effects to appear. And also the potentially most sensitive abilities don't even develop until adolescence, things like executive functioning. So there's an argument to be made for measuring late. Challenge number 4 just involves doing research in children at all. In this case, we can't do a randomized control trial. The GAS study tried very hard to randomize and control, but ultimately we're talking about clinical anesthesia. All of the children we're talking about have some sort of underlying condition that required them to get surgery. And ultimately, the parameters, the duration of anesthesia, dose, age, all of these things are ultimately clinically driven in the end. There's also an issue with this exposure before age 3. That whole terminology came from animal studies. And we're probably trying to find critical periods and that anesthesia exposure affects. But we know that there's a huge range of normal in development. Are those critical periods the same for all children? Are those critical periods the same for all outcomes? Probably not. The other thing we obviously have to keep in mind is that there are other things that are more strongly associated with the outcomes than the medical parameters. And this has been shown in every single type of medical outcome studies that have been done. Sociodemographic factors are more predictive of outcome than any of the medical parameters. Also, we have to keep in mind when we're talking about research in children is heterogeneity. So in summary, when looking at the challenges of neuropsychological assessment in children after anesthesia, it's challenging. Cognition is not directly observable. You need a proxy to get to the underlying construct. There are challenges related to what to measure, how to measure, when to measure, and even who we're talking about. One child in a clinical evaluation versus many children in a research study. There are challenges related to stage of development at both exposure and outcome that we have to think about. And we have to remember that there are other factors that impact both the outcome and the measurement of that outcome. So ultimately, we're trying to assess real life functioning. And if we're going to get to a phenotype, we probably need to combine a lot of different measurements. We probably need performance-based tests, informant ratings, patient-reported outcomes, qualitative measures, and diagnoses to get to that underlying phenotype, if there even is one. So I will leave you with this reference slide, and I think I'm the last speaker, so I look forward to the question and answer.
Okay, thank you very much for all the speakers for these excellent talks. And we have a couple of questions, but I would maybe like to start with questions, with some questions to all of you, because there were some general themes that you touched upon. You touched upon the lack of a clear phenotype and also the difficulties to evaluate what would be the best outcome to test. So maybe if you could, each of you could comment on what would you recommend at the current stage of our knowledge on what would be a standard sets of tests which we would need to use for future studies already. And I'm not only talking, I'm mainly not talking about everyday clinical practice, but in future studies, what would be the best set of tests to use? If maybe if Andrew could start and then we go in order.
But it depends what your question is, and you do it. There's no point in fishing, so you have to have a reason to want to do a particular study or to have a particular question. And if you have a particular question, then you use the test. But the wrong thing to do is to go out there and just use everything on everybody. That's not science. So if there's a biological plausibility based on preclinical studies that particular domains are likely to be affected, then you tailor the tests to those particular domains. The problem, of course, is the translation from that to the neuropsych testing is not a perfect science. Or if clinicians in their clinical practice have an impression that there is some phenotype emerging, then you look at that to see if that impression is actually true. But more big fishing expeditions are probably not the big way to go. But it's controversial.
Yeah, that's why I wanted to take this as a first question. If you have Caleb, can you comment on this? You have to unmute yourself.
I agree with Andrew that fishing expeditions are problematic. But this question is tricky because we know that we are not going to find major differences in kids. We would have noticed that if that was the case. So it would be great if children actually presented to neuropsychologists or other physicians with developmental issues after anesthesia. But I think that the differences that we're finding, if we're looking at a 2-point difference, which is a 0.2 standard deviation, you may not find that by just looking at 1 or 2 children. You may need to look at entire populations of children in order to actually measure that type of difference. I think that we're getting a little bit closer to what we should be measuring based on many fishing expeditions that have been performed. And the effect seems to be within the behavioral realm. There are other studies that look at clinical diagnoses that may be related to behavioral issues such as ADHD. So I think that may be a direction that we can move towards. There appears to be potentially some primate data suggesting social interaction issues as well. So I believe that may be an area that we can move into, but I'd certainly be interested in hearing what Cindy and Kristen have to say.
Absolutely. Please, Christine, if you go first.
Yeah, I mean, I really am in agreement as well with Andrew and Caleb that really depends what we're trying to assess and what age group we're trying to assess and what time frame we're interested in. So whether we're looking at outcomes that we're worried about in the first few days after surgery, or whether this is something that we're looking at more long-term, like 6 months to a year out. So it really informs our metrics. And I think really looking at clinical significance, what do we feel like is actually impairing patients' functioning or their quality of life, rather than just what types of blips can come up on questionnaires.
Okay.
Yeah, it's interesting. I agree with everyone else, what they said. People have asked me, because of my involvement in this research, you know, if you had my child was exposed to anesthesia, do you think they need a neuropsychological assessment? And I can tell you that I've never had a referral clinically where anesthesia exposure was the risk factor that I was assessing clinically an outcome for. in preparing for this talk, though, rather than answering your question directly, Laszlo, I do think we need to think about this critical period question, because the preclinical studies are so systematic. They have exposure at this time, they have outcome at this time, and children just don't work that way. So I've always been a proponent that, why do we care and why do we keep measuring this if it's not a big problem? But I have this nagging thing in the back of my head that's like, well, maybe we're just not being systematic. Maybe there is a critical period that is the risk, and we don't want to miss that. So I'll throw that out there too. Lots of ways to measure it, but I do think it depends on the question.
Yeah, I will come back to this because I think it's a very important part of all this critical period plasticity. But just because Andrew asked, it depends on what we want to measure, but do we really know what we want to measure in light of current evidence? Because, preclinical studies theoretically should drive the clinical research, but apart from some primate studies with a very low number of primates, it's very difficult to base our clinical research on preclinical evidence. I don't know if Caleb or Andrew want to comment on this, and then we could go back to the critical periods and the age. Andrew?
No, I agree. There are some primate studies, but they're fairly limited.
Caleb?
I agree that ideally there would be a strong body of evidence in the primate literature, and also a strong signal in the clinical literature. I think that what we're looking at, if it is anything, is going to be subtle, which makes it difficult to find a very strong signal. So that's what we're left with. Either it's a weak signal that is difficult to find, or it could be nothing at all.
Yes.
But I think you need to put it in the context that there's a lot of, we don't know a lot about a lot of aspects of neurodevelopment. We still have a very poor understanding of the etiology of even what happens to children who are very premature. So, and for things like ADHD, we still have a relatively limited understanding of the physiology of what's going on. So to expect a good understanding of something that might be fairly subtle it's just simply going to be extremely difficult.
Yeah, but I think, and this gets back to Cynthia's talk, as she explained quite in detail, that this famous 3 years cutoff is something that we could also discuss, because what we know in terms of neurobiology of development, that there are these critical periods, and depending on which system you are talking about, these critical periods are even at the age of 10 or even later on. So should we really focus, when we are starting to answer the question of effects of anesthetics on neurodevelopment, only to the young ones, or even, it's a big basket, even between 0 and 3 years of age, but maybe adolescents or maybe the 8-year-olds. I could also have biological arguments why to focus on older children. So maybe, Cynthia, if you continue a little bit the thoughts on this.
Yeah, I think it's an interesting question. The other thing we know about just normal development in children is that these critical periods aren't the same for every child. Even when you talk about something that's pretty well established, like language, for example, most children have a burst of language between 18 months and 2 years of age, but there are perfectly typically developing children who have that burst of language later. And I just think it's very hard to, I think, again, we're going backwards. We're studying based on theory as opposed to taking the preclinical studies and using them to then translate to children. It's a tough question. I don't know if.
Yes. I don't know if Kristen wants to add something to it. No, okay. So we have several questions here, some of them are answered, and maybe we will not have time to go through on each of them, but we still have a couple of minutes to go. So maybe we can start with Valerie Villeneuve. Is there a link between 2 points difference in children receiving general anesthesia and post-op delirium and agitation? In other words, whether postoperative delirium or agitation is linked to longer-term behavioral outcome?
The evidence for that is extremely weak for a number of reasons. The measures that we have for postoperative delirium, people use different measures, so there's variability. And the measures we have for long-term behavioural change are not particularly good, and we can come back to that and discuss whether the PAHBQ should be sort of relegated to the bottom drawer. There are some studies that show a link, but I'm not convinced there's any science behind there being a causative link between delirium and long-term behavioural changes. I know, and even in adults, there's debate as to whether delirium is a meaningful link between delirium and outcome. And in children, I just don't think the mechanism of postoperative delirium is a sort of neurotoxicity mechanism. So I'd be very surprised if there's any link between post-op delirium and long-term behavioural changes. But I could be wrong.
Anybody disagrees? If not, we can go further. Vinicius from São Paulo asking whether there is a study comparing volatile anesthesia with TIVA in terms of outcome measures, in terms of postoperative behavior changes.
Certainly for delirium, if you use TIVA, there's a lower incidence of delirium. That's very well described. But once again, there isn't any good evidence to show that it has any impact on long-term behavioural change.
So I would have a question as an anesthesiologist and non-psychiatrist or psychologist to Cynthia and Kristen. I mean, you both showed all the challenges and how much it's time consuming to perform all these tasks. Do you think that at the current stage of knowledge and evidence, is there a place for systematic testing of children in a way that maybe we could imagine that it would be nice, because then we could maybe have a feedback on what kind of clinical management or perioperative management had this or that effect, but it takes hours if I get it right. So is it really worse in at the current stage in everyday clinical practice, or is it's something that's more reserved to academic activities?
At least in terms of more of these long-term behavioral outcomes, I don't think that we really understand what is normal and what isn't for kids post-surgically. So I would agree, and that's what I'm more interested in looking at. What is kind of the bell curve of response to kids after surgeries, barring that there aren't any unforeseen events that happen during the surgery, but in like a regular surgical course, what do we even expect kids to respond with at 2 weeks, 4 weeks, 6 months? And we really don't know. We don't know what's pathological and what is completely normal.
Mm-hmm.
So I would say my quick answer is no, that we shouldn't systematically be looking at all children exposed to anesthesia and evaluating them. But there's an interesting question in the QA. And one thing we might want to think about is the high risk children. So children who have other risk factors for poor outcomes. There's a question about autism and increased behavioral problems after anesthesia. If we're talking about more long-term outcomes, though, maybe we should be studying the higher risk children and seeing if they have an additional risk of anesthesia because they're not typically developing already. But I would say the systematic evaluation of all children.
There's quite a few centres around the world routinely follow up neonates who have had major surgery for neuropsych assessments. I don't know what age they follow them, but it's become almost routine in many places because they have such a high incidence of problems.
I think it matters too what we're talking about with follow-up assessments. So in terms of a neuropsychological battery that is very time consuming for kids, families, and the neuropsychologist, I can imagine that's something that we wouldn't want to do on every child. But if we have these brief screener measures that we can use to better get phenotypes of kids who are going to have adverse outcomes, behavioral outcomes after surgery, then I think that's something worth investing in and using widespread.
Caleb, something to add? Because your talk, you had some suggestions that maybe we should look into more in detail on this psychological test to choose what would be the best combination. That's why I'm asking whether you have other opinion or it's still for academic.
So I agree that routine evaluation of children who have received anesthesia for deficits probably will not yield a large signal. Again, given the subtlety of what we would be looking for, I think that if anything, we would be finding an effect in a large population, and it would be, again, a small effect. So I agree with Cindy that probably wouldn't be that helpful in relatively healthy kids with a short exposure to anesthesia.
Mm-hmm.
But Laszlo, there were a couple of questions about measuring delirium in children, and
Yes.
there's very little, if any, literature looking at hypoactive delirium in the first few days in children after anesthesia. So there's quite a lot in the adult literature, but it's an area which, if you're a keen young researcher, to try and better understand how many children actually have. We know a lot about emergence delirium, but we know very, very little about delirium that happens in the first, second, or post-operative day, or once they leave the PACU. And there is that one, the Cornell scale for measuring delirium in children, but I think that is the only one that I've seen, and that's not widely used yet.
Yeah, so that was a bunch of questions I wanted to extend upon on hypoactive delirium, because I think it's something that we start to recognize more and more in pediatric practice, especially given some new data. So what do you think, Andrew, is that really matters? Because so far we were basically just very happy that the children were quiet in the PACU and it went all, but do we know something how it can relate to length of stay or whatever else? Do we have any data on that? Should we care about hypoactive delirium, or should we be just happy that they don't?
Well, it probably matters in adults. In pediatrics, we don't even know if it occurs. We certainly don't know whether it matters. If it doesn't occur, then it probably doesn't matter.
There are also some questions which comes back all the time, which are purely clinic. When we see the parents, what should we tell them? And I think it was very clear from the 4 presentations that there is no yes or no answer, but parents usually like binary answers. It's yes or no. So how do you approach this? It's a question always coming back in these webinars. But so what do you tell the parents based on current evidence? Maybe Caleb, if you...
That are more important than the anesthesia that we can actually intervene on to create healthy, happy, smart kids.
Mm-hmm.
Well, I think that we continue to go with the statement that we don't have concrete evidence that there is a detrimental effect, but delaying surgery and anesthesia can be detrimental, particularly if it's necessary surgery. So I don't think that there's too many people who are recommending a change in clinical management for children.
So related questions are, it's an anonymous one. whether parents want to know what permanent damage their children are at risk for. I mean, that's what we were discussing, that we don't really have a phenotype. So it would be very difficult to answer this question to the parents, to what kind of specific risk they are facing. Actually, we don't have a phenotype on this. Do you agree with this?
So I think that so what we're talking about is in terms of finding behavioral differences. What we're saying, well, what it appears is that it may be subtle, but we're still trying to determine what the cause is. We've discussed, could it be some type of other hypotheses that have been raised? Or could it be the traumatic experience of going to the hospital, the surgery itself? Could it be some type of physiologic perturbation? Could it be underlying issues in the children? Or could it be the anesthetic medication itself? So I think that if we're asking what is the permanent damage due to the anesthesia, I don't think it's necessarily been shown. It appears that there may be some subtle differences in children who have had surgery and anesthesia, but we don't necessarily know what it is. So it's hard to make a recommendation if you don't know the mechanism behind it at this point.
Yeah. Maybe we have time for some other questions regarding the delirium.
Yeah, just correct. I think I made it when I was saying before, we don't know what the incidence of delirium is. We've got a bit of an idea of the incidence of hypoactive delirium in the recovery, but after recovery, we don't have much evidence for what the hypoactive delirium is, just to differentiate between the two.
So one of the questions regarding delirium is, what's the timing of giving propofol to decrease postoperative delirium? Is there anything known about that?
If you think of it sort of pharmacokinetically, you have to give enough so that the child emerges from propofol anesthesia rather than volatile anesthesia. So if you get in your mind the washout between the two, they've got to be waking up from the propofol. So usually you've got to give about 2 to 3 milligrams per kilogram very close to the end, which is of course enough to make the child apneic and prolongs the awakening.
That's the pharmacokinetic way of thinking, but do we, maybe there is evidence, but I don't know about whether there are some studies showing this, that you have volatile anesthesia and then at the end, like 10 minutes before, 15 minutes before, you give 2 to 3 milligrams per kilo of propofol, and then you decrease the emergence delirium, the incidence of emergence delirium. Do we have any data on that?
Yes, if you give enough towards the end, you do reduce it, yes. That's in some centres, it's a fairly common technique that a bolus of propofol is given at the end of the volatile anaesthetic.
Okay. Another question is there any research suggesting whether it's the anesthetics versus a stressful induction of anesthesia that cause the maladaptive behaviors postoperatively? I don't know about that, but
I think there's very limited research. The only thing that's interesting is the gas study, where children received the surgery in the GA and the regional. I guess that's the only study where both children got the induction of the anesthesia, the pain, the hospital exposure. And it would be helpful to have more evidence where children could be randomized to just having a difference in the anesthetic.
okay, thank you very much. We are arriving to 60 minutes, so we have to unfortunately finish the discussion as well. So I would like to thank all the attendees and obviously the panelists for preparing these excellent talks and updates. And again, all this discussion will continue on the IARS website, and hope to see you soon in real life, sooner or later, I don't know when. So thank you very much and take care, and good night or good morning. Bye-bye.